I'd like to help distinguish for the listeners, the different types of medications that we use for mood issues, because there's a wide variety and most people don't have any idea how these things work.
So, I'll bulk them into the category of traditional antidepressants. And they all work in similar ways to different extents on what we call the dopamine and serotonin pathways. They The concept is that mood issues are fundamentally related to these pathways or to lack of stimulation of these pathways. And the goal of things like SSRIs or SNRIs are all geared towards that primarily. Ketamine works fundamentally differently. So it kind of approaches an old problem from a new angle. And like I said, it's a medication with a new use. So while it's been around for a long time, it's never been applied until more recently to this problem. But I tell my patients, this is something that's sort of reassuring to me about ketamine because it's been around for so long that it sort of stood the test of time. We're not talking about a new medicine with a new use. It's an old medicine with a new use. But what it does, it works in multiple ways and it kind of wears multiple hats. But the unique way in which it works is that it works on the glutamate pathway. And what it does is there's an NMDA receptor in the brain. And what ketamine does is it blocks that receptor. Now, that receptor blocks glutamate. So if you think of it as sort of a double negative, it blocks the blocker. So it unblocks, it opens the channels for the glutamate to pass through. More glutamate is better in terms of mood, motivation, and it has a direct antidepressant effect, glutamate, but it also works to promote the process of what we call synaptogenesis, of literally forging new pathways in the brain.
The medical community, of which I am a part of, hand out SSRIs like candy, especially to women. It's the answer for everything. And especially in perimenopause, we're already experiencing, most of us, weight gain. We're already experiencing low libido and sleep interruption and all these other things. We're adding that drug on top of it is going to exacerbate it. And then some of it, almost all of them contain warnings about suicidal ideation too. So they're not necessarily benign on top of that.
Right, right. I think it's a lot of sort of inertia, like psychological inertia, and not, just doing the same thing again and again and not realizing like maybe we have to think outside the box. And the nice part about ketamine, I think increasingly it's been more accepted in the medical community as a viable option. And I believe that the threshold should be lower before we start waiting till, a patient fails, and by fails, I mean doesn't respond to or can't tolerate, an SSRI or an SNRI or the like. And so that's what we're trying to get out there. So, we opened these clinics to make this accessible for our patients, but we also did a bit of education in the psychiatric community in terms of, we're physicians. We have certain medical standards. We're doing this because we really think it can help. And we hope that the patients that return to their psychiatrist will be like, this really helped. Maybe it can help some, other patients, and it'll sort of have a snowball effect. That's our hope.
Yeah. Yeah. It's just a lot of stigma around it. Now, I want to make sure we cover, because this gets looped into several other drugs. So NMDA, so I'm going to go back and sort of step on that, because those of us from the 80s might remember the street drug name ecstasy
Right.
that was out there. And so it gets that stigma. And then there's also psilocybin and the psychedelic. So it sort of gets looped into a psychedelic, but it's not quite the same in its mechanism. So can you distinguish those? Because some people are like, man, I'm not doing psychedelics. It's like, well, it's not really that.
So what I alluded to before was that ketamine wears a lot of different hats. And so it does have transient psychedelic effect during the actual treatment, but it is short-lived. So during the actual ketamine treatment, people can feel a little detached from reality, kind of like a little bit of a dreamlike state. I find that this actually helps a lot of patients that are suffering with PTSD, where they are able to have that sort of emotional distance from some of they want just that relief from the burden of carrying that trauma around all the time. So I actually find that even in the short term, it can be helpful for some patients. But regardless of what happens during the actual treatment, the ketamine is building up in your brain and doing the things that we know it does best. So, ketamine has that psychedelic property. And so, therefore, it can be looped in the category with psilocybin and some of the other psychedelics. Um, those other psychedelics have to be distinguished from ketamine. Ketamine is a bona fide medication that's, like I said, used in the medical community, established. It's an FDA approved medication. Again, it's used for other things like anesthesia, sedation. And part of the reason it's helpful, for instance, in sedation is it gives that if somebody comes into the emergency room and has a shoulder dislocation and they need it relocated, you can get ketamine, and guess what? You won't remember exactly what happened during the treatment. It won't be traumatic to you because you have that kind of you know, that you had that transient effect. But the idea is that it's similar. There's overlap in the Venn diagram, so to speak. There is overlap because it carries that property. But psilocybin and the other psychedelics have not yet been approved. There's no protocols in terms of how it's been studied. Ketamine has been studied for 10 to 20 years in the IV form. Spravato is the nasal spray, and that is FDA approved for treatment-resistant depression.
So let's talk a little bit specifically around, why you might see women in their 40s and 50s seeking out this treatment. Obviously there's a bunch going on with hormones, which I've talked about. But, if we look at the stats, at least one of the more recent studies I read, it was like 3 in 5 women experience depression, 1 in 3 experience anxiety as a primary symptom of perimenopause. And it's not all just the hormones. Yes, I would love to say that's true, but it's not.
Right. Right. I think women have sort of unique challenges that predispose them to sort of mental health issues. And while at any age you can struggle with depression, anxiety, and there's always sort of the intersection of biochemical, genetic, and stressors, environmental factors that always play a role to different extents at any age. But I think that what we've noticed in our center is that women can struggle earlier on in their lives, in their motherhood years, where they're continually sort of emotionally giving to others, sometimes neglecting their own mental health wellness. And then later on in life, where there's also that common thread of hormones and environmental factors, where maybe they're experiencing an empty nest syndrome or midlife crisis issues, combined with these hormonal changes to kind of create this perfect storm of an uptick in depression and anxiety. And we have patients that 18 to in their 80s. I mean, so really kind of can span any time. But I think that what we've noticed with our patients is that women can struggle with, unique set of issues in their menopausal years. And we try to sort of help people during that time. And I think as women co-founders, we hope that patients feel comfortable, coming to our center and knowing that their needs will be met.